Welcome to Module 2 on Person-Centered Language for individuals who work in acute care settings. This presentation will take 10 minutes to complete. In this module, we will do the following. 1. Define responsive behaviors. 2. Practice documenting responsive behaviors using person-centered language. The term responsive behavior has been introduced in healthcare settings in an effort to move away from labeling patients and instead encourage understanding about the meaning behind the behavior. Responsive behavior refers to behaviors exhibited by people who are experiencing an altered cognitive state or impairment as they respond to internal or external factors. These behaviors are actions, gestures, noises, or words used by patients to express or communicate something important about their personal, social, or physical environment. One or more of the following health conditions may be contributing factors in the expression of a responsive behavior: dementia, delirium, psychosis, acquired brain injury, stroke, and substance-related intoxication/withdrawal. Every word, gesture, or action provides important clues about the patient's unmet needs. This is important to keep in mind when documenting behaviors in a patient's chart. Specific, objective, and respectful descriptions of the behavior help us to see the person first and prompt us to gather information about the patient to guide care planning. Let's look at an example. The term non-compliant gives us very little information about what the behavior is and when or where a person is exhibiting this behavior. Describing the behavior with specific details, such as person pulls arm away during morning care, provides a better sense of what is happening and helps us consider the best ways to respond to the behavior and approach the patient. Does provision of morning care cause the person pain? Do we need to consider providing analgesic prior to delivering care? Or does the person prefer to do morning care themselves? How could we support the person to do their own care as much as they are able? Perhaps the person is modest and uncomfortable with being bathed. Specific and objective language eliminates vagueness and supports our assessment and monitoring of behaviors. Let's reflect more on the value of clearly describing what is happening when we document or describe a patient's behavior to others. Person-centered language helps us consider the meaning behind a behavior. This can stimulate care planning and generate ideas to support patients with behaviors. Let's consider these examples. If a person is collecting food under the sheets, it's possible they may be hungry. Or perhaps they have lived through economic hardship or military conflict and think they need to create a stockpile of food. If they are refusing bathing, it might be because they are feeling cold. Is the room chilly? Or perhaps they feel embarrassed at being bathed by a stranger. Are they worried that someone might walk in and see them undressed? The person walking about the hallway during mealtimes perhaps wants to use the toilet before eating. Or perhaps they want to see what other people are eating. Perhaps they are unaccustomed to eating at this time or eating alone. Perhaps the food or presentation of it is unfamiliar and they need assistance with their tray. The person who pulls a continence brief off and rubs their genitals may be described as inappropriate. But this doesn't help us to determine the meaning of the behavior and would be labeling the patient in a negative manner. Person-centered language gives a clear description of the behavior and prompts us to wonder, could this person have a yeast infection that is causing irritation? Could their continence brief be soiled or wet? Do they feel a need to use the toilet? These examples are specific, objective, and respectful. They help us think about the meaning behind the behavior and prompt us to see the person behind the behavior. Think of how different this could have been if a vague or non-person-centered language was used. The first person would have been labeled as a hoarder, and the next as resisting care, the third as a wanderer, and the fourth as sexually inappropriate. Would those words have helped or hindered the care planning process? Let's look at this slide and contrast it with the previous one. The descriptions on this slide are vague, nonspecific, and negatively biased. Vague words like these can mean different things to different people and provide the care team with little to no information. important detail and context about what, where, and when the behavior has occurred is missing. Will colleagues be able to easily know what the behavior looks like and if there is more or less of it? What behavior is considered non-compliant, inappropriate, or difficult? These words and labels don't provide us with enough information to know what is happening, when it happened, or if it is getting better or worse with our interventions. They also shape our expectations and perceptions of patient behavior and impede or undermine efforts to see the person behind the behavior. Seeing or hearing certain words like aggressive or violent predisposes us to feel on guard and to view all actions as precipitants to violence when this may not be the case. Think back to the previous slide and compare the descriptions there to this slide. Which slide gives you the clearer understanding and expectation of patient behavior? Which one will help you to plan your care? Using person-centered language guides the care planning process and helps us to clearly assess and monitor responses to our interventions. Does using person-centered language mean that you must eliminate certain words like confused or agitated or aggressive? It may seem as if you are being asked to completely avoid words like confused or aggressive in your documentation. There may be occasions when you will need to use these words, such as if they are part of a validated tool, legal form, or drop-down menu in an electronic documentation system. Using person-centered language means that when you do encounter situations that require you to use these words, you attempt to add specific and objective descriptions of behavior. This will reduce the possibility of labeling the patient and improve the chances that others will have a better idea of what is happening. Documentation has clinical and social consequences for our patients. What we leave out can be just as important as what we leave in. Listen to this quote from a clinical team lead from a hospital discharge planning team.
What is really important is for the documentation to reflect the what and the why and the intervention and the outcome when responsive behaviors are encountered. The words aggressive or exit-seeking are used in the patient's chart without additional comments about what might have been happening at the time, like needing the toilet or other needs. Failure to have fulsome documentation leads to home and community care, and in turn, long-term care facilities drawing inaccurate conclusions because they have limited objective data.
This e-module was developed by the Regional Geriatric Program of Toronto, with support from Behavioral Supports Ontario, BSO, Provincial Coordinating Office. It builds on the e-course Person-Centered Language, an overview for long-term care team members, which was co-developed by BSO and the Ontario Centres for Learning, Research and Innovation in Long-Term Care, CLRI, at the Research Institute on Aging, RIA, in collaboration with Mac Health at McMaster University and supported by an expert panel.